Good morning and welcome everyone to my third progress report. My PhD thesis is titled Adenomyosis and Infertility. Let me summarize my first project in a couple of sentences. So the problem is that adenomyosis patients have only a 19% chance of live birth during frozen embryo transfers, which is 40% lower than in patients without the condition. GnRH agonist treatment could improve pregnancy outcomes in this population. So we did a systemic review and meta-analysis, and we found a 47% increase with the use of the pretreatment. This result wasn't mathematically significant due to the high heterogeneity and low case numbers, but we still would consider offering this treatment to these patients. However, further randomized trials and high-quality research is needed to confirm these results. So, a bit about myself. My name is Máté Botos. I'm a third-year gynecology resident and a first-year PhD student at Semmelweis University. My vision is to have improved pregnancy outcomes for women with adenomyosis. And my mission is to find the most effective assisted reproduction technique for infertile women with adenomyosis. To achieve this, I have two ongoing projects. Let me start with the first one. It's titled Investigating the Efficacy and Safety of GnRH agonist pretreatment before frozen embryo transfers in women with adenomyosis. So adenomyosis is a condition where the endometrial tissue invades the myometrial layer of the uterus. The exact prevalence of this condition is not very well established, but studies suggest a prevalence between 12 to 58% in reproductive age women. Why is it important? Well, women with adenomyosis not only face a higher risk of infertility, but even with the use of assisted reproduction techniques, they have an almost 30% reduction in their chances to achieve clinical pregnancy. This treatment works by downregulating the ovarian hormone production, which is beneficial for creating and maintaining artificial hormone cycles. My aim is to investigate the safety and efficacy of this GnRH agonist pretreatment before frozen embryo transfers in infertile women with adenomyosis. So our clinical question is that does GnRH agonist pretreatment safely and effectively increase live birth rates in infertile women with adenomyosis undergoing frozen embryo transfers? I'm not going to repeat every part, but our main outcomes will be the pregnancy outcomes, of course, the live birth rate, the clinical pregnancy rates, and the biochemical pregnancy rates. Our hypothesis is that endometrial pretreatment can increase live birth rates in infertile women with adenomyosis undergoing frozen embryo transfers. And the clinical implication would be to contribute to assisted reproduction technique guidelines for women with adenomyosis. We ran a systemic search in 5 databases with more than 6,000 hits. And on this slide, you can see some figures from our manuscript. This is the PRISMA flowchart. You can see the selection process in detail. We found 72 articles eligible by title and abstract, and out of those we found 10 articles eligible by full text. We also done the risk of bias assessment for each article and the grade assessment. So this is our main outcome, live births. So we calculated the odds ratio for live births, and odds ratio it means that if it's above 1, then with the use of pretreatment, the chance of live birth is higher than compared to the control group. You can see we have 2 plots for this outcome because we have data based on IVF cycles and the number of patients. On the first plot, we have around 1,400 cycles included. On the second, we have around 1,000 patients. We have quite high heterogeneity in both groups, possibly due to the different type of populations that were included in the articles. You can see the per cycle pooled odds ratio is 1.47, which means patients who received pretreatment have a 47% increase in their chances to achieve a live birth. This data hasn't reached mathematical significance, but I think it's clinically relevant since the difference between adenomyosis and non-adenomyosis patients was 40% in the beginning. We have very similar outcomes for the clinical pregnancy rates. It's a slight decrease in the change of the odds ratios. It's around 1.32 for the patient-based data. You can see the first project progress in this slide. You can see the manuscript writing is the only step ahead of us. Out of this, the results and the method section is already written. We are setting the deadline for each section for the end of until the end of the month. And yeah, our conclusion is that the GnRH agonist pretreatment of patients with adenomyotic uteruses might have an advantage during frozen embryo transfers to increase live birth rates. This means that in the clinical practice, we can offer GnRH agonist pretreatment in certain patients to increase number of live births, but it has to be assessed on an individual patient level. And of course, this is a very important implication for research because we need high quality randomized controlled trials to assess the efficacy of this treatment and also have detailed answers for the dosages and the treatment lengths and in what population this treatment is the most effective. And now on to the second project, which is titled Comparing the Efficacy and Safety of Fertility-Sparing Treatment Options for Adenomyosis. So we talked about the effect of adenomyosis on fertility, but it also causes other significant issues, for example, and most commonly dysmenorrhea, but abnormal uterine bleeding, pelvic pain is also common. Different surgical and medical treatments are available for these issues. And our second project focuses on the surgical treatment options, which can be either excisional, like adenomyomectomy with laparoscopy, or robotic surgery or open surgery technique. And non-excisional techniques are, for example, ultrasound, radiofrequency, microwave ablation, or uterine artery embolization. And it's very important to find the best treatment for this population because excisional treatments seem to raise the risk of uterine rupture by almost 6%. So safety is a critical concern of ours. And additionally, the non-excisional techniques also offer an alternative to patients who are not eligible for conventional surgeries. My aim is to find the safest, most effective fertility-sparing treatment option for adenomyosis. Our clinical question is, which fertility-sparing treatment option is the safest and most effective in reducing symptom severity in women with adenomyosis? So the population is women with adenomyosis. The interventions are the ones I listed earlier. And we would like to investigate 3 types of outcomes. The first would be the efficacy in the reducing symptom severity. Secondly, the reproductive outcomes. And of course, we would like to assess the adverse effect rate in with these interventions. Our hypothesis is that minimally invasive techniques are safe and effective treatment options for adenomyosis. And the clinical implication would be to provide a clear guide for medical professionals who are treating women with adenomyosis. We've done the systemic search for this study. We have more than 5,000 hits, and we have done the title abstract selection, and we are currently doing the full text selection with around 300 eligible articles. We have a deadline also at the end of this month. To summarize, I have 2 ongoing projects. I would like to submit the first one at the latest until this September, and the next one until the January of 2026. Thank you for your kind attention.
I have a question. Thank you very much for your nice presentation. And adenomyosis is a disease with an unknown etiology. Yeah. Are you agree with that, or you have new information?
No, I don't have new information on that, but yeah, it's very clear that the scientific community doesn't agree on a very clear.
Because of that, we are only trying the different treatments.
Yeah.
And yeah. What about the effect of the GnRH analog treatment? What is your opinion that how is it working? What is the mechanism?
Okay, thank you. I think the most important effect of adenomyosis on the infertility or fertility is the way it disrupts the embryo implantation during the embryo transfers. So I think the idea behind a pretreatment is to prepare the endometrium for a later implantation. And the hope is that the implantation rates and the clinical pregnancy rates would be elevated with the use of the pretreatment, which can be at least 2 or 3 months, basically. Thank you.
Nice presentation.
Thanks.
Is there any guideline for the treatment when to choose the surgery and when not? You know.
No, these are very novel techniques. So the international guidelines doesn't really have enough evidence to give these options to clinicians confidently, because we don't have quite enough data for this recommendation.
And for these cycles, and in your first topic, you have your forest plot, and there is some difference between among the first articles and the last one, and what could be the difference that, as I remember,
yeah, there are a couple of articles with basically no effect, and a couple of with very high positive effect. Our hypothesis, because we don't have really enough data to support our hypothesis, but so it stays a hypothesis, but it seems like the problem is that these are retrospective cohort studies, and we hypothesize that patients who received the pretreatment had worse or more severe conditions than those who didn't receive the conditions. So we are really comparing apples with oranges, because we're not very similar populations, probably. One of the articles which has a very high change in the odds ratios actually homogenized the population by saying only moderate severity adenomyosis patients can be included.
They selected them.
Yeah.
So, okay, thank you very much.
My question is there any data that GnRH agonists infect the congenital abnormalities?
I haven't come across any data like that, so surely there has to be, if it would have, then it would be assessed before it became widely used in the assisted reproduction techniques, so I don't believe it does, because you have to know that this pretreatment only, so it comes before the implantation even begins, and it doesn't, so the embryo transfer is after the pretreatment, so this drug isn't given while the patient is pregnant, so only before that.
Thank you.
Thank you.
Any questions on the floor?
Yes, please. Congrats. So this pretreatment, how long would it be?
Well, it's around this, across these articles, it varied very widely. It's between 4 weeks and 3 months, basically. Any shorter doesn't really seem to have any effect, and any longer isn't. It doesn't seem that any longer treatment than 3 months has any benefit.
All right. And after surgery, how long would you wait for starting the IVF treatment?
It's a very different question. It depends on the type of surgery. So I think it's if it's a open adenomyotomy, when there is a high risk of uterine rupture, I would wait, I believe, at least half a year or 1 year before the IVF treatment. But it depends also on the patient's age as well.